Dr. Ted Venema Talks Audiology, the educational whiteboard series brought to you by Next Gen Hearing.
Hi, I'm Ted Venema, here to talk to you about hearing aids. Hearing aids ain't eyeglasses. This is actually the first segment of a three-part talk on hearing aids. But let's look at hearing loss and compare it to vision loss. They're very different from each other. And when you get a better idea of who you're not, you have a much better idea of who you are. 95% of vision loss is caused because the eyeball is too long or too short. Have a look at figure 1. It shows an eyeball and it shows an ear. When you're looking at vision loss, if the eyeball is too long or too short, light is not focused properly upon the back of the eyeball, known as the retina. And in one sentence, the retina changes light into electricity, and electricity is the language your brain understands. As we said, 95% of vision loss is caused by a problem of conducting or getting light to focus properly upon an intact retina. Only 5% of hearing loss is caused by a blockage of sound getting to where it needs to go. This is the contrast between vision loss and hearing loss. 95% of hearing loss is caused by damage to the inner ear or cochlea. 95% of hearing loss is what we call sensorineural. This is akin to someone scratching the back of the eyeball and ruining the retina. Now go ahead and fit the glasses. Well, that's the role that hearing aids have to play. They have to amplify sounds and send them to a damaged inner ear, which in quotes is like the retina of the ear, the cochlea. Greek word for snail shell, cochlea. It contains thousands of little hair cells, and these serve to change sound into electricity. And again, electricity is the language the brain understands. This is what makes the big difference between glasses and hearing aids. And this is something so many people do not understand. They actually think that they can borrow their neighbor's hearing aids because, hey, hearing aids just make sounds louder. Not true. There's a lot more complexity to that than that. And it's kind of interesting. It's neat to check it out and look at what it is. When you've got sensorineural hearing loss, that's, as we said, like the retina of the ear itself having damaged. But what happens with sensorineural hearing loss? Here's one big thing that happens. The floor is elevated and the ceiling of loudness tolerance hasn't changed. Let's look at figure 2 because it shows this. When you're looking at figure 2, you'll see a horizontal axis and a vertical axis. The horizontal axis represents decibels from 0 up to really loud, 100 decibels. The vertical axis, well, that's showing one's perception of those different decibel levels, from soft to comfortable to loud. If you look at the 45-degree angle red line, that represents the loudness growth for someone who has normal hearing. For someone with normal hearing, 10 decibels sounds soft. For someone with normal hearing, 50 decibels sounds comfortable. For someone with normal hearing, 90 to 100 sounds too loud. Now look at the person who's got presbycusis, sensorineural hearing loss. And let's introduce that word, presbycusis. Sounds a lot like Presbyterian, doesn't it? Presbyterian means Church of the Elders, as opposed to the deacons. Presbyopia means your arms aren't long enough to read the page. You can see far, but you can't see near. Presbycusis means hearing loss in the elderly. So presbycusis is by far the most common sensorineural hearing loss around. And now let's turn our attention back to this graph. Look at the light blue line on the graph. That light blue line shows you the loudness growth for someone with sensorineural hearing loss. Note that 50 to 60 decibels now sounds very soft to the person. His floor is elevated. But look at how the lines converge or meet at the top. 90 to 100 still sounds too loud for the person with hearing loss that's sensorineural. For someone whose hearing loss is due to damage of the retina of the ear, the cochlea. So hearing aids for this person, think of what they have to do. For this person, hearing aids have to amplify soft sounds by a lot. In other words, they've got to exercise their muscle when incoming sounds to the microphones of the hearing aids are really soft. Then the hearing aid has to work hard to amplify. But as the incoming sound increases in loudness, the hearing aid automatically has to back off. So that loud sounds coming into the hearing aid, those aren't amplified at all. And again, the reason why is because of this graph we're showing you. A person with sensory neural loss, their floor of hearing sensitivity is elevated. Instead of being able to hear at 10 or 0 decibels, it takes them 50 or 60 to just barely hear. And yet 100 sounds too loud, just like it does to someone who has normal hearing. Hearing aids have to accommodate this fact. And the word used to describe what hearing aids do here is called compression. Hearing aids need to amplify soft sounds by a lot, average sounds by less, and loud sounds by little or nothing at all. Why do they call it compression? They call it compression because think of the dynamic range for someone with normal hearing. The person can hear from 0 to 50 up to 100 before it's too loud. Now take the person with sensory neural loss. I'm going to keep my hand up here. I'm raising up my floor. So notice how my range of hearing sensitivity from soft to too loud has shrunk. So hearing aids have to take a big range of sound and squeeze it into a smaller range. Notice my right hand isn't changing. My left is what's coming up. They've got to amplify soft sounds by a lot and loud sounds by little or nothing at all. Compression. In the next segment, we'll talk about hearing aids and their digital programs. And in the third segment, we'll talk about how hearing aids handle noise with directional microphones and digital noise reduction. Until then, thanks. Thanks for listening. See you next time.